is a Nightline Friday night special.
Take one 64-year-old retired school teacher with a failing heart. Add one major metropolitan medical center. Throw in a team of cardiologists. Add some nurses. Sprinkle with electricians, security guards, and food servers. Multiply by a 10-day hospital visit. And the result, a $64,000 price tag. Tonight, the anatomy of a hospital bill.
This is ABC News Nightline. Reporting from Washington, Ted Koppel.
If you've ever wondered how and why a hospital bill rises to the astronomical proportions that it does, stick with us tonight. Oh, and for the squeamish among you, there'll be very little blood. While a double bypass and a heart valve replacement is to the patient who needs it a priceless application of the surgeon's skill, later on, as we or our family members recover, it does cross our ungrateful minds that $60-some-odd-thousand is a whale of a lot of money. The December copy of Life magazine has devised an intriguing way of showing us why the high cost of medicine is so high. It's the ultimate how many people does it take to screw in a light bulb picture. Shot at one of the country's premier teaching hospitals, Georgetown Medical Center, here in Washington. The 4-page fold-out photograph captures the 98 people involved in one way or another in a double bypass heart valve replacement performed here last summer. A lot of people involved: priest, housekeepers, plumber, electrician. If you want to understand the high cost of health care, take a look at this picture. As Life magazine prepared to take the shot, Nightline was invited to come along to document the anatomy of a hospital bill.
My name is Bill Webb. On July 27th of this year, I entered Georgetown University Hospital to have open heart surgery.
Hello, the last row. We are fine here on this particular area here.
All the diagnostic tests that they ran didn't really quite indicate how bad it was when they got in there and actually saw it.
Good. Okay. Now stay right there.
They came to the judgment that things were really well blocked up.
Come closer. Come closer. Come closer. Closer. All the way forward. All the way forward.
So the choice was really, in essence, made for me. Not by the doctors, by the facts of the matter, of the case.
Now we're swinging the camera over and we do this group.
When we started, we had no idea how many people were involved. You obviously have surgeons, nurses, medical technicians. But as we began to look around, we saw administrators, we saw people in the pharmacy, housekeeping, and our numbers began to grow.
I think without this procedure back in July, I probably would not be alive today. Just that simple.
Okay, 1, 2, 3.
I'm the office nurse where Mr. Webb comes for his cardiac care.
I distributed body fluids of Mr. Webb to the proper labs.
I'm Mr. Webb's primary care physician and internist and okayed him for surgery.
Webb's first stop was to his family physician, a $250 visit for lab tests to determine if he was ready for surgery.
We had several discussions in person and on the phone for doing the procedure, his fears, his worries, how justified were they, and the chances of his dying.
I'll be very honest with you. I had a good life. I've had a good life up to this point, and I enjoyed it, every moment of it. And I'm not a believer in quantity of life if you don't have quality to go with it.
I scheduled his cardiac catheterization and his admission to the hospital.
I supplied the blood products for Mr. Webb's operation.
I did the hematology and coagulation studies for Mr. Webb's operation.
He had two reasons that he might have died suddenly. One was aortosis, and the other was coronary artery disease.
And there was no question that the proper treatment would be a double bypass operation as well as an aortic replacement. Without that operation, the prognosis for patients such as Mr. Webb would be only a 50% chance of surviving 2 years or more.
This room is where Mr. Webb came to get what's called a catheterization. This is a picture cardiologists take to determine whether surgery is required. They then give this picture to the surgeon, who uses it as a road map during the operation. For Mr. Webb, the bill came in this room to about $4,000.
I visited and prayed with Mr. Webb before and after surgery.
I purchased some of the supplies for Mr. Webb's heart surgery.
I was a scrub nurse in the operating room for Mr. Webb's surgery.
The operation itself involved removing a damaged valve, a valve that was both obstructive and leaking, and replacing that with an artificial valve. And then using an artery that runs under the breastbone to bypass an obstruction in one of the coronary arteries that supplies the heart muscle.
Webb's operation took 6 hours. Total charges, $36,000.
Our fees are really determined by what goes on by insurance companies. We don't say that this operation is worth so much and put a figure on it and expect to collect that. That may have been possible or was done in the past, but certainly isn't reasonable today.
I made sure Mr. Webb had clean sheets and blankets.
I was responsible for keeping Mr. Webb well ventilated and oxygenated after his open heart surgery. I helped distribute cardiac medications to Mr. Webb.
Mary Michael Brown coordinated the nursing in the intensive care unit where Mr. Webb came for the 9 days of his recovery after surgery. Here he was attended by 12 nurses around the clock. In the room, a heart monitor cost $23,000, a ventilator, $29,000, and a bedside defibrillator for $7,000.
Is all the machinery in this room necessary? I think so. It used to be in the olden days, before we had infusion pumps, we would have to take our watches out, place them next to the drip chamber, and time the amount of fluid we wanted to get in based on the sweep hand or the second hand of our watch. That is not a very reliable method.
Mr. Webb was billed an average of $1,200 a day for his intensive care room. Embedded in this room charge and throughout the hospital bill were the hospital's overhead costs. These included things like preparing patient meals, security, electricity, as well as the cost of covering uninsured patients, malpractice insurance, and the cost of running what is a teaching hospital.
Oh, thank you, dear, so much. Good for my daily ritual here. Some days they're up to, what, 8 or 9 of them. One of these days, hopefully, they'll take away half of this. I'll tell you, yesterday was the best little exercise for me that I've had since I got out of the hospital. Very good. I had that old treadmill going, you know. I've never done that before. I don't know. There's no question in my mind that the procedure has definitely, you know, improved in every way, you know, the quality of my life. I think basically I'm much more interested in things because, for one thing, the energy's there. I think the blood is getting to places it hadn't gotten to in a long time. I mean, just state it simply.
I'm the nurse that discharged Mr. Webb from the hospital.
I was responsible for properly submitting Mr. Webb's bill to Blue Cross.
I made sure Mr. Webb's bill got paid.
William Webb's final bill from Georgetown University Medical Center, $63,589.
The only comment really I can make on this is that I realize it's very expensive. In some ways, you know, you almost kind of feel guilty about it, really. But thank God the procedure was there, the people were there, the care was there, the caring people were there, and because I wouldn't be here today.
It was a beautiful, beautiful day.
When we come back, we'll be joined in the operating room at Georgetown Medical Center by the surgeon who performed the bypass operation on William Webb, by the hospital's chief operating officer, and by an executive of Mr. Webb's insurer.
This is ABC News Nightline, brought to you by Sears.
I was a circulating nurse in the operating room for Mr. Webb's surgery.